In the Consultant General Surgery Oral Board Exam, every verbal response is mapped directly to a numeric scoring rubric. Success depends on following a precise clinical algorithm where one missed step can end the scenario. The prompt is specific. A 25-year-old male arrives at the emergency department with a stab wound to the right upper quadrant. The injury occurred more than 12 hours prior to his arrival. His vitals appear stable. Blood pressure is 110/70, and his heart rate is 90 beats per minute. The patient is sitting comfortably with normal hemodynamics, yet half a day has passed since a blade entered his abdominal cavity. Selecting non-operative management based on these stable vitals results in an immediate fail. In delayed penetrating trauma, stability often masks an evolving catastrophe. A high index of suspicion is required to identify what the vitals are hiding. The candidate must first articulate the intention to follow the ATLS primary survey. As the rubric shows, the first 4 marks are secured by confirming an intact airway with C-spine protection and verifying normal breathing. The check continues through circulation, noting the absence of external bleeding, and disability, confirmed by a perfect Glasgow Coma Scale of 15. Only after these systems are cleared does the exam focus on the localized tenderness and guarding around the right upper quadrant wound. This sequence ensures that life-threatening systemic failures are addressed before the surgeon's attention is pulled toward the localized injury. Verbalizing the ABCDEs establishes the patient's baseline safety and demonstrates the discipline required for complex diagnostic problem-solving. The secondary survey begins with the ample history: allergies, medications, prior illnesses, last meal, and the events surrounding the trauma. To identify potential hollow viscous injury, the examiner expects questions regarding the presence and color of any emesis. Inquiring about rectal bleeding and stool color further narrows the search for upper versus lower gastrointestinal tract involvement. The candidate must then list the differential diagnosis by mapping the anatomy of the right upper quadrant. The search begins with the primary upper GI structures, the stomach and the duodenum. It expands to include the small intestine and the colon as they pass through the quadrant. Solid organs and biliary structures follow, specifically the gallbladder and the biliary ducts. Finally, the boundaries must be checked: the diaphragm superiorly and the major vascular structures within the retroperitoneum. This targeted history allows the surgeon to narrow a broad spatial differential into a focused investigational pathway. Immediate management includes placing the patient on NPO status, inserting a nasogastric tube for decompression, and beginning IV fluid resuscitation. The bundle is completed with analgesia, IV antibiotics, and baseline labs, including a complete blood count. Because of the wound's location, liver function tests are specifically required to evaluate the biliary system. Diagnostic imaging consists of a chest X-ray to evaluate the diaphragm and a CT scan of the abdomen with IV contrast. The CT scan identifies a retroperitoneal hematoma containing air bubbles. The presence of retroperitoneal air confirms a breached hollow viscus, making immediate surgical intervention mandatory. The only correct clinical path following this discovery is an exploratory laparotomy, which earns 5 marks on the rubric. The candidate must then describe the specific repairs they are prepared to execute once the abdomen is open. Strategies for the upper GI tract include gastric repair and, notably, duodenal repair or bypass. In a presentation delayed by 12 hours, tissue edema may make a duodenal bypass a safer alternative to primary repair. Lower GI strategies include repairs to the small intestine or colon and potentially the creation of a stoma. The plan is rounded out with cholecystectomy, biliary duct repair, and repairs to the diaphragm or vascular structures. Detailing these interventions proves the surgeon possesses a premeditated blueprint for every organ at risk in the right upper quadrant. The final phase of the exam requires the candidate to categorize the complications associated with this injury pattern. The list begins with the immediate systemic threats: hemorrhage and septicemia. The delay in presentation significantly increases the risk of septicemia due to prolonged exposure to enteric contents. This contamination also drives the formation of regional abdominal abscesses. A specific risk in this scenario is the duodenal fistula, resulting from the breakdown of the initial repair. Long-term, the laparotomy incision itself carries the risk of a late incisional hernia. Accurately predicting these outcomes shows the examiner that the candidate can manage the surgical patient through the entire recovery process. Successful navigation of the viva requires moving from ATLS baselines to the identification of retroperitoneal air and into a definitive operative plan. In penetrating abdominal trauma, stable vitals do not replace the need for definitive contrast imaging, especially when presentation is delayed. Mastering the oral board exam is a matter of transforming anatomical knowledge into a precise verbal algorithm that eliminates the possibility of diagnostic error.